Okay, team, today we're going to be talking about asymptomatic severe hypertension, how we treat it, should we treat it, and what's the role of PRN antihypertensives in the treatment regime. I don't particularly have any disclosures. So we've all had these nursing phone calls. Your nurse calls, Mr. Smith, your patient admitted with severe cellulitis, is noted to have a blood pressure of 175/80. Nurse is concerned, wants to know, what do you want to do about it? So the question is, do we or do we not treat that blood pressure? Now, blood pressure is something that we're very familiar with. 1 out of every 3 adult Americans have some degree of hypertension issues. So because we see it routinely, we feel like we have a certain degree of mastery over it. Now, in my view, I think doctors really should consider hypertension in 3 main camps: chronic hypertension and its management, hypertensive emergency, and asymptomatic severe hypertension. Now, my reason for talking to you all today about this is that I feel that we are applying what we know about chronic hypertension and hypertensive emergencies and then trying to extrapolate that into how we handle severe but asymptomatic severe hypertension. In other words, I think that there's a real and potentially dangerous gap in how we think about and how we're managing this population. Now, we all know JNC 7 and 8 guidelines and how to initiate therapies. So that's not what we're here to talk about today. So I think that what we know about the problems of chronic hypertension really drive our fears about taking care of this population. So this statement we've all heard before: for every 20-point increase in blood pressure above normal, we're doubling our vascular mortality. However, I think that we need to be more cognizant that the morbidity and mortality is due to the chronicity of the exposure more than the severity of the blood pressure elevation. To help me prove that point, this is the blood pressure readings for Franklin Delano Roosevelt for about 14 years. In fact, the last 14 years of his life. And as you can see, that his blood pressures were essentially 200/100s for more than a decade and a half. And in all that time, he's running the country for 4 terms. He's handling the Great Depression. He's getting us through World War II. So you can see that human beings can handle elevated blood pressures for a long period of time. Now, this is hypertensive emergency. We all know this. If your blood pressure is 180 or more, over 120, with evidence of organs being damaged, this is hypertensive emergency. We know the algorithm for taking care of this: decrease the MAP by no more than 25% and then slowly adjust thereafter. But what about this? What about that patient with asymptomatic severe hypertension? Sure, their blood pressures are super high, but they don't have end organ damage. And so how urgent should we treat these patients? How aggressive should we be in treating these patients? So today, we're going to go down the donut hole and take a good look at asymptomatic but severe hypertension and the role that PRN antihypertensives are playing in their treatment. Some questions that we want to answer today are these: is there significant benefit from aggressively treating this acute severe but asymptomatic hypertensive population? Are there potential harms to treating them? And if we are going to treat, exactly how aggressive should we be? So as you can see, there's a lot of hypertension and elevated blood pressures in the acute care setting. So we're constantly exposed to the question of what to do about it. And as you can see, there are a lot of situational reasons why the patient's blood pressures could be elevated in the acute care arena that impacts our understanding of what their baseline blood pressures and hypertension control really are. Now here's a key slide and a bit of a kicker. No studies have shown that aggressive blood pressure lowering, even in hypertensive emergency situations, is of benefit acutely. But, and it's a big one, aggressive blood pressure lowering creates the potential for adverse consequences. So let's start with the outpatient perspective. This is a 2016 study trying to answer the question, should severe asymptomatic hypertensive patients be managed on the inpatient or outpatient setting? This is a retrospective review, and about 1/3 of these patients were referred on to the ER in the hospital for treatment, and about 2/3 were handled outpatient. The outcomes that they looked at were major adverse cardiovascular events, ultimate blood pressure control at 1 to 6 months, and admissions to the hospital at 1 and 4 weeks. So, as you can see, there were no major differences in major adverse cardiac events. And I want you guys to cue in on this. The rate of having such an event was extremely small, less than 1% at 6 months. The outpatient group was admitted to the hospital less, and at 6 months, the blood pressure control in both populations was just as good. And that led this research group to suggest that there didn't appear to be a very good reason to send severe but asymptomatic hypertensive patients to the ER or to the inpatient setting for aggressive management. Quote, no substantial benefits were found, end quote. Here's a study from our ER brethren, and they asked the question, does elevated blood pressure in the ER mean that you even have hypertension? They followed 239 patients who presented to the ER with essentially stage 2 blood pressure ranges to see what their blood pressures did without intervention. As you can see, only 35% of these patients ultimately were found to even have hypertension. In other words, 65% of the patients with significant blood pressure elevations in the ER did not have hypertension, and thus we can extrapolate would not have benefited from initiation of antihypertensives. Here's another good one from our ER colleagues. This one was from 2015, and they looked at outcome differences in approximately 1,000 patients that were divided into acute treatment versus no treatment at all. Now, nobody likes a bounce back, especially not our ER partners. So they were probably pretty happy that there was no difference in return visits at 24 hours and 30 days. But more importantly to us, they found that there was no difference in 30-day and 1-year mortalities. So not intervening in the emergency department for severe asymptomatic hypertension is a very safe strategy. Okay, it's time for a perspective break. I'm going to read this to you. So in large-scale randomized trials, pharmacologic antihypertensive therapy as compared to placebo produces a nearly 50% relative risk reduction in the incidence of heart failure, a 30 to 40% relative risk reduction in stroke, and a 20 to 25% relative risk reduction in myocardial infarctions. And let's look at that from an absolute benefit perspective. Well, it turns out that with appropriate blood pressure treatment for 4 or 5 years, when patients with essentially stage 1 blood pressure findings, this provides a coronary event benefit of around 0.7% of patients and a CVA event of around 1.3%. So total absolute benefit is only about 2%. So here's the translation. 100 patients need to be treated for about 5 years for us to prevent an adverse cardiovascular event in 2 patients. So I point all of this out so that we can get our minds around the overall impact of all hypertensive patients as it applies to the individual patient. So the benefits that we're used to thinking about when we treat elevated blood pressures are really found at the population level more so than the individual level. So let's summarize the benefits of aggressive treatment in this population. It doesn't decrease admission rates, it doesn't improve major adverse cardiovascular events, and it doesn't improve mortality at 1 year. So we really need to keep that in mind as we're pondering the benefits and harms. Okay, let's dive into the harms risks. So much of our fears about the use of PRN antihypertensives come from our experience with the use of sublingual nifedipine. And here's a great example of why. We can see a patient gets a single dose of nifedipine in about 18-25 hours, and 30 minutes later their blood pressures drop drastically from 220/110 to about 75 or 80 systolic over 50 diastolic. Here's why this should worry us. Normotensive patients have no problem controlling end organ perfusion by means of autoregulation down to a MAP of 60-65. But, and here's the key, chronically hypertensive patients can lose this control and develop perfusion injuries at much higher MAPs. And this is due to a relative hypotension compared to their typical hypertensive state. So when we couple a powerful vasodilator with a population with potential autoregulation issues, we aren't surprised to see that nifedipine use was linked to all kinds of bad outcomes, from severe hypotension, strokes, heart attacks, even death. So I see it as progress that we don't use this medication any longer. But I can see where some of you are probably thinking, but we don't really use nifedipine anymore. Our PRN antihypertensives are safe to use, so what's the big deal? Okay, well, let's take a look at today's PRN antihypertensives. So here's a single center retrospective study looking at the use of PRN, hydralazine, and labetalol. Over a 1 year period of time, you can see that 7.4% of all of their patients were exposed to PRN blood pressure orders. But, and this is a big one, less than 3% of the orders were for an appropriate indication. So if you're screwing something up 97% of the time, the good news is it should be pretty easy to make improvements. Now, here's an interesting finding, especially if you're a hospital administrator. Those folks who did get the PRN antihypertensives, they increased their length of stay by about approximately 5 days. So when you start to think about further exposures to risk, when you start to think about increasing costs to the patients, this is a big deal. Here's another 2018 retrospective looking at the use of hydralazine and labetalol. This looked at the impacts of both oral as well as IV administration. So I include this slide to point out that of the 573 doses that the patients did get, about 204 of those doses were for blood pressures that wouldn't even have been considered in the urgent range. That's about 35% of every order. So here's the good news. There were no associated severe adverse events with the use of PRNs. So that's great. We didn't cause our patients to have any strokes or acute kidney injuries. But look at this. 22% of the patients receiving a PRN exceeded the safety mandate to limit the change in blood pressure to less than 25% of the MAP. And of course, that comes to us from the Hypertensive Emergency guidelines. So to my way of thinking, this means that 1 in 5 of our patients are going to be put at risk when we use these medications. Look at this. So the impact of the PRN use had an interesting effect on prescribing habits. 41% of these patients were not restarted on their home meds during their hospital stay at all. 32% of them only got restarted on their home regime 2 or more days after they got to the hospital. But most damning of all, we were giving out PRN blood pressure medicines, but then we neglect to modify or start a chronic blood pressure regime 63% of the time. This does not seem like good care. There seems to be something about the use of PRN antihypertensives that interferes with our ability to have a logical and safe approach to managing chronic blood pressure issues. So here's a very interesting 2018 study looking at what's more important, high blood pressure or the patient's susceptibility to that high blood pressure. Specifically, they were looking for benefit to treat patients with low risk for mortality or cardiovascular disease who had mild hypertension. And they defined low risk as anybody who did not have cardiovascular disease, LVH, AFib, diabetes, CKD, or family history of premature heart disease. This was a retrospective study looking at about 17 years of data on stage 1 hypertensive patients. And basically, the cohort was divided into those who had been, quote, exposed to antihypertensives, let's call that treated, versus a population that went untreated. As we can see from the graphs, there was no discernible difference in mortality, vascular disease, heart attack, or stroke between both of those cohorts. However, there was an increased risk in the treatment exposure arm for hypotension, syncope, acute kidney injury, and electrolyte issues. So this study suggests that your patients at low risk for vascular disease with stage 1 hypertension, there was more potential harm in treating them than to just ignoring it in the first place. Now, I know I'm at risk of really overbeating this issue, but I want to share this study with you for a reason. This is a single center study, 6-month retrospective looking at PRN hydralazine use. And as you can see, the rate of misuse is very similar to our previous studies at 98%. We see that range for overcorrected blood pressure of about 20% was also found. So here's the reason why I felt that this study added something to the conversation. Look at what happens to the change in blood pressure as you go up in quartile of blood pressures. The change is much larger as the blood pressures go up. That 4th quartile, those with the worst elevation in blood pressures, some of those people saw 60-point drops in their blood pressure. So my fear is this: those at the highest risk of an autoregulation injury, those chronically elevated hypertensive patients, those may be the patients that are most likely to get a very large response to their PRN medication. And if that's the case, then we're really setting those patients up to be at risk for a potential ischemic injury. Okay, so let's summarize. When we use PRN antihypertensives, we're exposing our patients to potential harms at a rate of about 1 in 5. Furthermore, the habit of utilizing PRN seems to be stopping us from appropriately addressing the patient's chronic blood pressure regimes. All right, let's switch it up a little bit. So here's another phone call. Nurse Steve calls us and says, Mr. Smith, that guy that you started on Norvasc the day before, his blood pressure is still 168/80 today. Would you like to do something with that? And so really what Steve is asking here is, do you want to add a medicine or change the dose? Now, I don't know about your experience, but in my practice, I've seen interns, residents, attendings, subspecialists, multiple specialist teams all make daily changes to a patient's blood pressure regime. It's pretty common practice. So here's the issue with that practice. We have no idea if we've picked the right dose of a medication for 4 to 6 weeks. That's how long it takes for you to get to steady state when you initiate an antihypertensive. So for those of us who have a foot in both the inpatient and the outpatient world, have you ever noticed a trend of your hospital follow-up seeing you a few weeks after discharge with a complaint of weakness, dizziness, and orthostasis after having their medications adjusted in the hospital setting? This could be the issue. So this is the A-time study, which looked at the impacts on the velocity of dose acceleration. So this study involved titrating 2 cohorts of hypertensive patients to reach goal blood pressure control with quinapril, with the only difference being how quickly the follow-up meetings occurred and thus the titration of the medication. So the fast group was seen at weeks 2, 4, and 6 after initiation of treatment, and the slow group was seen at 6, 12, and 18 weeks. So this graph is measuring percentage of success at reaching goal blood pressure, and as you can see, the slow groups consistently outperform the fast titration group at each follow-up. So here's the important takeaway from the A-time study. The adverse event rate was basically identical for both groups, but the severity of the adverse events was almost twice as likely to occur in the fast titration group, which I think makes intuitive sense to all of us. So much of our conversation thus far has been to highlight a human failing. We frequently tend to overestimate the benefits of an intervention and underestimate potential harms of intervention. Though Medscape was calling out physicians as a group in this 2016 description of the phenomenon, I think it's a part of how human beings are wired. Now, having said all that, this is not a conversation about not treating hypertension. It's about doing it in the most effective and beneficial way possible. And for that, we're going to turn to our pharmacy friends in Colorado who published this gem in 2016 that I think represents a solid and logical approach to considering treatment or not in the acute asymptomatic hypertension population. Their main concept here is to identify the at-risk population, those who are most likely to be injured by the severe hypertension in a shorter time frame. And thus, we're going to use that risk assessment to guide urgency of treatment. This group proposed that we use these criteria for at-risk stratification. So those who already have a history of CHF, coronary artery disease, CKD, TIAs, or strokes. So the first step in the algorithm is to fix secondary issues that might be exacerbating or even causing elevations in blood pressure. So I've highlighted here the most common issues that I encounter in the acute care setting. We haven't started them back on their blood pressure regime. They're out of control with pain or anxiety. They're super volume overloaded from that 5 or 6 liters of NS that they've gotten since they hit the hospital. That sort of thing. Maybe they're going through withdrawal. So this is the proposed algorithm for the low-risk population. Having found no significant history of organ disease, we need to fix the secondary issues. If the issue persists, the breakpoints are: is there a history of known hypertension, and is the phenomenon with the vital signs persistent or intermittent? If they have a history of hypertension, but the blood pressure spikes are only intermittent, it's probably safe to just observe that patient. If the blood pressure elevations are persistent, well, maybe that dose of Norvasc just isn't getting it done, and now it's time for us to make a small regime adjustment. On the other hand, if there's no history of hypertension, if the vital signs are intermittent, then observation alone is appropriate. Remember, from our ER study, only 35% of people with elevated blood pressures, even at stage 2 levels, actually had hypertension. So observation might be appropriate for that population. On the other hand, sometimes people need to be diagnosed with hypertension. So if the vital signs are persistently elevated, fine, maybe it's time to make that diagnosis and get that patient started on appropriate chronic treatment. So this is the proposed algorithm for those that are at risk. It's a bit more aggressive. In my opinion, I think it's weakly channeling the spirit of our fears about hypertensive emergencies. So as you can see, if you've got these risk factors and you've corrected all the underlying issues that might be driving the blood pressure up secondarily, then this team of pharmacists felt that it might be appropriate to give a single dose of a short-acting and, most importantly, oral antihypertensive to try and get that blood pressure down below 160s over 100s, and at that point start to make decisions about changes to blood pressure regime. To be honest, after considering all of the literature for the past 4 months, I'm not sure that I'd give the PRN myself. But I do agree with the recommendation to be vigilant about monitoring for incoming evidence of end-organ insult. So just don't forget that 20% of folks who receive PRNs are going to get a greater than 25% drop in their MAP when you make the decision to give a PRN. So this position paper seemed to favor the use of low-dose clonidine, both for its pharmacodynamic properties, as well as its general lack of contraindications for special populations, such as giving labetalol in a person who's in heart failure or heart blocks. Probably not a great idea. And almost all my patients have CKD or AKI when they get to the hospital. So the use of a PRN ACE inhibitor is probably not going to turn out to be a workhorse for me. So that's why they like clonidine. It's pretty short acting, doesn't suffer from a lot of the other contraindications. They specifically call out hydralazine, and they do not recommend its use as a PRN, whether that's oral or IV, due to what we already talked about, its unpredictable dose response, as well as the risk of reflex tachycardia that could certainly worsen angina or even induce a myocardial infarction. So let's wrap this up. We're all prone to overestimating the benefits of acute hypertension interventions and underestimating the risks. The short-term benefits are hard to find in the literature currently. The harms or risks don't seem to be frequently life-threatening, but they do exist, and they are impacting the quality of our care, costs, and do expose our patients to a fairly high incidence of potential harm. So in summary, I want to leave you with these ideas. Do not treat asymptomatic severe hypertension if it's transient and situational. You need to assess your patient's actual risk of end organ damage when deciding how aggressive to treat that patient. Do not aggressively accelerate treatment regimes. And try to avoid the use of PRN antihypertensives, especially IV medications for non-emergency treatment. Here's the listing of all my references so you can check my homework and study for yourself. I want to acknowledge student Dr. Berman/Wingfield as well as Shihada for their assistance in journal selection and review of the literature to help prepare this. And we've made it to the end.